Hello, everyone. Welcome. My name is Meg McElroy. I use she and her pronouns, and I work as a project manager on the Getting to Zero Illinois plan. I'd like to welcome everybody today to our webinar. It's great to have people from across the state of Illinois join us as we discuss ending the epidemic in the COVID era. This is the first in a series of webinars that Getting to Zero Illinois is going to be co-producing with our statewide partners over the next couple of months. So please stay tuned and keep an eye out for information about our future ones. Before we hand things over today to our presenters, we're going to go ahead and be discussing PrEP and cisgender women, as well as PrEP in our rural Illinois communities. But first, I'd like to cover a few housekeeping things with everybody who's on for today. So today's session is going to be recorded. We're going to share it out to all registered participants, whether people are able to be with us today or they registered, they'll receive the slides as well as the recording. So please feel free, once you get those, to share those amongst people in your networks as well. Also, during the program today, only our presenters' cameras and microphones will be on, just for ease for everybody who's on the webinar, and everyone else will remain muted. However, the chat and the Q&A functions will be monitored during the session for any questions that people have. So please feel free to go ahead and type in questions or comments during our presenters' presentations as they're speaking, and then we'll elevate those as we have time. As a quick refresher for everyone, Getting to Zero Illinois is a statewide initiative that aims to end the HIV epidemic in the state by 2030. Through partnerships with community-based health organizations, healthcare providers, government agencies, people living with HIV, and others throughout our statewide community, we'll carry out the plan built by Illinoisans for every region across the state. This plan is different in many ways than other states' plans, other national plans that we're seeing come out of the federal government. It's really a way for us to build access to all kinds of care, not just HIV care. It focuses on shared goals, shared best practices, and an understanding of what it takes to help everyone thrive. So specific to today's presentation, we're going to be talking about PrEP. PrEP is one of the key pillars of the Getting to Zero plan. Pre-exposure prophylaxis, or PrEP, is available as a daily pill and program, though other formulations are in the pipeline. By investing in the increased awareness, access, and use of PrEP in key priority populations, we will be able to truly drive down the number of new HIV transmissions across our state. However, we want to ensure that PrEP is used and available to everyone that could benefit. For a very long time, cisgender women have been left out of research, education, marketing, and outreach campaigns for PrEP. So we're excited to have several presenters here today with us to go ahead and discuss that population's unique and specific needs. We also have a presenter here that's going to speak about PrEP in our rural communities and how, for many people, providers are few and far between, and providers might, or patients or clients might have to drive many hours to speak with somebody who's knowledgeable about PrEP. Again, please feel free to jump in the Q&A or the chat and share any questions or comments you have for us or our presenters. Now I'm going to go ahead and turn things over to our three presenters, Jessica Ridgway, Lisa Hirschhorn, and Amy Johnson, who will be discussing PrEP and cisgender women.
Great. Thank you so much, Meg, and thanks everyone for lending us an hour of your time. I'm going to just very quickly, each of us is going to introduce ourselves, and then we're going to do a little bit of a sort of tag team talking about the work that's been done in terms of understanding and working to improve PrEP knowledge, access, and uptake among cisgender women in Chicago. And the great thing is there's so much work. The challenge is 20 minutes, but we'll do the best that we can. So my name is Lisa Hirschhorn. I am professor at Northwestern University Feinberg School of Medicine in the Department of Medical Social Sciences and Psychiatry and Behavioral Sciences, and I'm also chair of the Scientific Working Group for Ending the HIV Epidemic. And I've been working in HIV since I started my residency back in the 1980s, and so it's really very exciting to be here. Amy?
Hi everyone, my name is Amy Johnson. I use she, her as my pronouns, and I'm a research assistant professor at Lurie Children's Hospital and Northwestern University.
Jess?
Yeah, hi, I'm Jessica Ridgway. I am an associate professor of medicine at University of Chicago, and I also use she, her pronouns.
Great, thanks so much. And I use she, her pronouns. And now I'm going to share my screen and hopefully share the correct presentation. There we go. Great. So I'm going to just start off with just a couple of backgrounds and then go into some of the work that I did along with Jessica and a number of other people, including Amy, and then we'll continue on from there. So in hearing from you, especially about that second part for PrEP and cisgender women in Chicago. So what do we know? We know that 19% of new HIV infections in the US occur in cisgender women. Estimated about 176,000 heterosexually active women have indications for PrEP use in the US. And the PrEP is sort of very important because it's a very private, user-controlled method, empowers women to protect themselves, that women's PrEP use has been extremely low. And 2019, a meta-analysis found that PrEP knowledge among women is very limited, ranging from none of the women who were interviewed to 33%. But on the other hand, the willingness to use PrEP was much, much higher, between 61 and 97%. Now, what's happening in Illinois? We know that in Illinois, what's called the PrEP to need ratio, which is how much is actually PrEP for the people who actually need it, is 9.2, which is about 2.8 times higher than for women, indicating that fewer PrEP users among women relative to their need for PrEP, despite really some fantastic work that's been done to raise awareness. 4% were men, so only 6% were women, and in comparison, women represented 17% of all new HIV diagnoses in 2018, each one of these women representing a missed opportunity. So there's been, like I said, really a tremendous amount of research that's been done on PrEP and cis women in Chicago, and you'll hear about some of these. This includes the I Know study, an STI and an emergency department, family planning and reproductive health clinics, an abortion clinic. Then there's been work looking at what's called PrEP persistence, what we know about providers' knowledge, attitudes, and barriers. And then finally, what's been some of the work developing, implementing, and evaluating interventions to address this gap between PrEP and uptake. So I'm going to start with a study that I led with a number of colleagues here, as well as people from CDPH, from the AIDS Foundation Chicago, from CWAP, among others. And it's called I Know. It was designed to say, what did women know and think about PrEP? These were women who were not on PrEP, who were coming for care at a CDPH clinic or the University of Chicago emergency department. What we found was, using what are called the PrEP that women would have, that about a third of these women met those criteria. But only 30% of the women overall had heard of PrEP, and it was not all of the women who met the guidance. And only knowing someone on PrEP, an odds ratio of 15.6, meaning they were 15 times higher, was predictive of pre-existing knowledge. About a third, though, considered starting PrEP in the next 6 months once it was explained to them what it was. And there was a lot of really issues around empowerment, protecting their health for 3/4 of those women, as well as reducing HIV worry for a little bit over half. Now, we wanted to know not just sort of what did women know and what were they thinking, but how could we actually begin to think about addressing some of these barriers? And so we asked them, well, if you were to take PrEP, where would you prefer to get your information, and where would you prefer to get your PrEP? And what we found was that wanted to get their information from, so 49%, apologies for the formatting, wanted to get it from the regular primary care provider, about another 35% from another healthcare provider, about a third from an HIV prevention program, and about a quarter from a family planning clinic, and as well as some for internet search. When we asked, where would you like to go to regularly get your PrEP? Again, over half of them wanted to go to their regular primary care site, and smaller percentages to other places. We then wanted to say, well, what are your concerns and what support would you need? And not surprising, and this was seen when HIV treatment, about 2/3 of women were worried about that. About a quarter of people women had concerns about it being ineffective, medication interactions, the burden of taking daily pills, and finally cost. and then about 20% of women, 19%, had no concerns at all. When we asked them what kind of support would you need, about a third of them said they would need financial support, about another third for adherence support, and 18% said that they would really want some support in how to disclose to their partner about taking PrEP. So these are really areas that we can sort of listen to and learn from these women to understand how do we actually address information, access, and support. So they had a couple of advice for us. We had some focus groups and some interviews. They said educate providers and empower women. I'll go pull out my phone and say, I'm glad you got some time because I'm paying right now to see me. So give me a second, let me go on Google and pull everything out. And now you do have the information PrEP. We're going to sit here, we're going to get this knowledge together. Feeling about how do we actually help the provider to respond to this empowerment of women. Again, this focus on the regular sources of care and, importantly, trusted providers to be ready to support not just the access, but the side effect disclosure and financial support. And very importantly, adapt the messaging that we've been doing and engage women as messengers. One woman told us basically you're going to have to get a lot of more African-American women to get out here and advocate for you all. Because if it's coming from you all, the interviewer, only thing they're going to take a look at is the dollar sign behind it. I'm going to be honest with you. You all need to get some more African-American women that are actually from the streets, that's tired of the street, and have them advocate for you all. So really very clear messaging about. Over to Amy to talk about some additional work that was done in family planning clinics. Amy?
Great, thanks, Lisa. So yes, I crammed everything into one slide, so I'm gonna stay on the slide for a little while. But a lot of the work that we've done to date has been in family planning clinics. And the reason for that is that 60% of cisgender women cite family planning clinics as their primary source of healthcare, with 40% of them citing it as their only source of healthcare. And so we know that a lot of cis women are accessing care through family planning clinics. And so we thought that this would be a really great place to integrate PrEP, as well as other HIV prevention tools. So this work started in 2017 with a Society for Family Planning grant, in which we did community meetings and stakeholder interviews to really identify what were the gaps in knowledge and potential intervention opportunities. And through that, we identified really the need for additional observational research and the need to document women's experiences in Chicago in family planning clinics. And so that's exactly what we did. And so we next conducted a study among adult women, adult Black women, ages 18 to 45. So in reproductive age, our mean age was 28, or actually close to 29 years old. Participants were potentially at increased risk for HIV due to all of them were living reported condomless vaginal sex, recent abortions, and STI testing. But many of them reported that their risk for HIV was low. So their risk perception of HIV was really much lower. And they also, 68%, the majority, reported they had zero chance of contracting HIV. And so this was an intervention point that we really see as, something that we could impact is risk perception and understanding more about what might increase your exposure or risk to HIV. In this same study, about 35% reported hearing about PrEP prior to enrolling in the study, but then once they did hear about PrEP, through the study, 74% reported that they would probably or definitely take PrEP. So this is similar to the stats that Lisa talked about in the beginning slides that we see nationally. So Chicago is in line with that national data. The most frequently endorsed barriers when talking through PrEP, so once we gave them a little bit of information about PrEP and how PrEP works, there were concerns about side effects. This study was done in 2018, but women also reported feeling the drug was too new. And then there were some cost concerns. So we really found that these barriers could be mitigated by some knowledge and some support, some informational campaigns, and some dialogue around that to ease some of those worries. And so they're not insurmountable barriers. They're barriers that we can address. The next thing that we did was another observational study, but this time in a population that was a little bit different. So this was with young Black women ages 12 to 24. So it's an adolescent population. A lot of my work focuses specifically on adolescents. So in this population, similar to adults, the young women had a really low perceived risk of HIV infection. They really didn't feel like they were at risk of acquiring HIV. But interestingly, half of the participants, over half, 53%, had heard of PrEP prior to taking part in the survey. And so the messaging and the education, just a year later is reaching younger people. And so we see that that's different than, kind of the 33% that we see nationally. PrEP meant you were promiscuous. So we asked about like perceptions of PrEP because we thought that might be a barrier to taking PrEP. And we were really excited to see that they weren't thinking that. They also, about half felt like using PrEP might result in risk compensation. So, increasing behavior that might put someone at increased exposure to HIV. And about a third suggested that instead of taking PrEP, they felt like people should just choose their partners more carefully. So again, just giving some insight into what young women are thinking about HIV prevention strategies for themselves and other young people. Finally, in this vein of PrEP and family planning clinics, we have a current study with, it's a dyad study. So it's among Latina mothers and daughters. And this actually came about from doing our study with young Black women in family planning clinics. We found that the young Black women were coming to clinic appointments by themselves. Girls were coming with their moms. And so we saw this as an opportunity to leverage the strength of that relationship and really understand more about how we could promote HIV prevention tools and PrEP using the strength of that relationship. So that study is actually currently enrolling. We're about halfway through enrolling in that study. And so results to come. So,
thanks.
Right.
Jessica, over to you.
Great, thanks. So, Amy and Lisa have talked very eloquently and summarized a lot of the work that we and others have done around cis women initiating PrEP in Chicago. And so this is sort of a follow-up study to some of those earlier studies, trying to look at PrEP persistence, because as we all know, it's not just getting the prescription and starting to take PrEP. It's the whole PrEP continuum of care and helping women. So this was a partnership between some of us in the Third Coast CFAR and Howard Brown Health, with the collaborators, as you can see on the slide. And what we did, we had a mixed method study trying to understand factors associated with PrEP persistence. So, which women, start PrEP and why do they choose to continue, and women who start PrEP and stop. Why do they choose to stop? And we're still doing some of the analysis from the study, but just some preliminary themes and some preliminary things we heard from women were that for them, the women who had persisted on PrEP, a few of them likened it to taking birth control pills. It's a pill they take every day. They're both related to sexual well-being, and that was a way that they were able to persist on PrEP, as they sort of viewed it as something similar. We also heard that PrEP navigators were a really strong facilitator for cis women for both starting PrEP, but also staying on PrEP. So having with payment, help them schedule their PrEP follow-up appointments. And then the other thing that women were saying was that it has to be an internal motivator for them to persist on PrEP. It can't just be, seeing their medical provider who says, keep taking it, you need to keep taking it, that it's really requires this internal motivation. And they would say, you have to want to do it. Next slide. And then this is sort of the quantitative aspect of PrEP persistence. And this analysis was done by Maria Pyra at Howard Brown, and she looked at PrEP persistence for the women who, for Black cis women who had started PrEP at Howard Brown. And so for this study, persistence was defined as having enough PrEP pills to cover 6 out of 7 days each week for 6 months. And so we wanted to see what are factors that we can look at, doing a medical record review to see, who persists on PrEP. And their PrEP persistence was 19%. So it sounds, it is somewhat low, but it is comparable to other rates that others have seen as well. And interestingly, she did find that that living on the south and west sides were associated with lower odds of persistence. People who came in with their chief complaints, so they came in persistence compared to people who came, for some other reason. So having PrEP be the reason for the visit was associated with higher odds of persistence. Also, the more recent year of PrEP initiation was associated with the lower odds of persistence. So there's something about people, the cis women who started PrEP, back in 2015 were more likely to continue on it as opposed to women who are starting more recently. And then the other things that she looked at were not associated with persistence. And then finally, as part of this study, we also wanted to talk to providers to try to understand, why are providers choosing to prescribe PrEP to cis women? Why are there providers who aren't prescribing PrEP for cis women? And try to understand the provider's perspective in terms of their barriers and facilitators. And what we heard from providers were that they lacked a formal protocol for identifying candidates for PrEP, especially in cis women. They said they had a hard time, trying to figure out which cis women should be on PrEP. They also reported that from their perception, there seemed to be a discordance between, women who they thought would be good candidates for PrEP and women's self-perceived risk for HIV infection. And then they talked about needing more information and knowledge regarding PrEP in African American cisgender women community. They said that they would appreciate more training and better ways to approach PrEP with women, and how to talk to them about it, how to identify people who would benefit from PrEP. And then they also said that having PrEP care teams, so again, having PrEP navigation teams and others to help support the providers are things that really do facilitate PrEP uptake in cis women.
I think we're going to Amy now.
Invention strategies. And so one intervention that we piloted, this was funded by a CFAR, Northwestern CFAR Pilot Award, in which we created an mHealth app to promote knowledge of PrEP in family planning waiting rooms among young Black women. And so we designed this app in collaboration with 10 young Black women who designed actually all aspects of the app. So you can see a little screenshot. That is the character that takes folks through the app. Her name is Michelle, and they completely designed her, which is kind of fun. App that really primes participants not only with PrEP knowledge and awareness, but also gets them ready for their clinical encounter. And so it helps them establish different questions that they might have about HIV prevention or sexual health promotion strategies right before that clinic visit. So this would happen in the downtime when you're waiting for your clinic visit. And so in this pilot study, we developed the app and then we pilot tested it with 50 young women in 60% of our participants reported never having heard of PrEP, and despite qualifying for the study based on sexual risk-taking, so condomless sex, they consider themselves very unlikely to be at risk for HIV. So very similar to what we were seeing in our observational studies. Overall, their participants considered and the app is called In the Loop, the In the Loop app feasible and acceptable to use while waiting for their family planning visits, with 92% saying they would recommend the app to their friends, and they rated it highly, a 4.6 on a 4.3 on a scale of 1 to 5, 1 being very poor to 5 being very good. And so we're hoping to take this to the next level and really refine the app and then test it in a larger sample using an RCT design. So that's the next step for this.
Great, thank you. I'm going to turn this over now to Jess to talk a little bit about some of the work that's a little bit more provider focused.
Yes, absolutely. So, you know, based on some of the things that we heard from these earlier studies and, you know, hearing from both women and providers, these are some thoughts we have for next steps targeted towards providers PrEP to cis women. So the first piece is, you know, using the electronic medical record in a better way. And this really can span the whole HIV, or no, sorry, the HIV PrEP candidates. So facilitate, you know, identifying people who would benefit from PrEP. And so you know, we've at University of Chicago built an EMR, embedded EMR alert to try to identify candidates for PrEP who come in through the emergency department. And I know that others have, you know, throughout the city and in the nation have done something similar, you know, to try to use, you know, things like, you know, electronic alerts and best practice alerts to try to, you know, help prompt providers to talk about PrEP with patients and to prescribe it for them. But, you know, something that's really interesting that we found is that, you know, we built this alert. We had, you know, basically developed a risk score and built this alert into the EMR to try to, you know, identify folks who would benefit from PrEP. But then when we went back and validated the risk score, and it really was missing a lot of cis women who went on to seroconvert and become HIV positive. And, you know, there's other folks who have, you know, also developed these sorts of, you know, even like big fancy machine learning algorithms to identify women, or sorry, to identify patients who would benefit from PrEP. You know, so, you know, some studies out of, you know, Harvard with Doug Krakauer and Julia Marcus, and they found that they had, you know, really good accuracy in identifying men who, you know, seroconverted and became HIV positive, but they did not work for women either. And so this is, you know, a really tricky area. It's really, I think, hard to find things in the electronic medical record to that give a clue that a cis woman might be at risk for HIV and would benefit from PrEP. But some of the things we've looked at and are trying to look at to improve this sort of identification tool are, you know, STI testing patterns, you know, things in the social history or other things in the past medical history. You know, even using the EMR to alert, just to help providers take a better sexual history, so that you can elicit some of these things that are relevant and important. So, and then in addition to just identifying PrEP candidates, then there's, you know, you can use the EMR to facilitate the PrEP prescriptions. You know, these are the labs you need at baseline, having order sets and that sort of thing. And then we're also working on a tool in collaboration with some folks at Alliance Chicago to try to develop sort of a population health management tool to track PrEP outcomes. Because we want to know, you know, can we use the EMR to say, like, these are all the people who would benefit from PrEP. These are all the people who started it but haven't come back, so that we can really, improve the quality of our care for cis women on PrEP. So that's the EMR piece. And then the other aspect that we want to focus on, and I think that we heard a lot from both providers and women, is just additional training for providers, about how to communicate with cis women about PrEP. What are the PrEP indications? The CDC has certain indications. We know that those don't always line up with people who actually would benefit from PrEP. But how do we, talk to providers, in that gray area so that they can have the conversation most effectively with women who, can ultimately decide what's best for them and their health.
Great, thank you. So this brings it to a conclusion, and I just want to thank on behalf of my
and then also trainings in PrEP prescription.
Sorry, Jess, I lost you.
No, go ahead, sorry.
So I just want to thank the audience for their attention, and to all our collaborators and researchers working to increase PrEP among cisgender women. This really does reflect a cross-city collaboration and many people. Very importantly, the women who generously gave us their time, their opinions, and their advice, the providers who are committed to improving PrEP access and uptake and sharing their experience and needs, and a number of different funding sources, including administrative supplements to the Third Coast CFAR for AIDS research, a pilot grant from Third Coast CFAR, the Society for Family Planning, University of Chicago Women's Board, Northwestern University, and a Third Coast CFAR Community Award. And with that, I think we are done. I guess just, next steps in getting to zero is, cisgender women must be a priority if we're going to get to zero new infections. These women and their providers have insights into how we can do better. And so what questions do you have? And just giving you as well our 3 contact emails. So Meg, back to you.
Yes, thank you all so much for not only your work on this topic, but sharing with us today. We have a couple of questions that have rolled in. The first one is talking about, and this is a lot of, Jessica, what you've addressed. So one of the barriers we hear from providers is how to introduce PrEP to cisgender women in a responsive and respectful way, avoiding stereotypes and pitfalls, which could damage the patient-provider relationship. Can any of you 3 kind of walk us through 1 or 2 ways about bringing up this topic during a patient-client interaction?
Sure. So I think and if my internet is cutting out, let me know. I'm sorry. I think it's been a little bit blotchy. But I think the most important thing is just to really comfortable with the conversation, that patients can tell. And I think that as much as you make it a routine part of all of your conversations with all patients, and you tell patients that this is a conversation you have with everyone, and you mean it, then I think that that's one way to really introduce it. And I think in general, people are not offended. And when we ask patients, will you be offended? They are not. And they're happy to talk about their sexual history, and especially in framing it in a way of like, I care about your health. I talk to every patient about this. I think is the best strategy.
Yeah, no, I would just agree with that as well. And I think, this goes back to when we were doing sort of positive prevention and still doing that, is getting providers really skilled and comfortable with taking sexual histories. I think they're not particularly helpful, not particularly comfortable, but also then making sure that they have the knowledge. If the woman says, yes, actually I'm interested, that providers have the feeling of like, I know how to do this, I know who to send them to, I know how to make that next linkage, because I think there's also a fear of like, I'm going to offer something and then have no idea, as well as then sort of making sure the system's ready to respond.
I'd just like to add too, from the patient perspective, we've done quite a bit of this research with women collecting information. And I can't remember one woman who said, I was like, so offended by talking about PrEP. I think that, you know, they're interested in it. Like you see it in our data and in the responses. Once they hear about PrEP, they're like, well, why didn't I know about this? Why am I just finding out about this now? Even if they don't feel like it's an okay option for them in that moment, it's still, you know, they want access to the information so that they can make the decision along.
The other question that we had earlier in the presentation, it was mentioned that, quote, disclosure to partner was a barrier. Does that mean disclosure that the person is on PrEP or disclosure of potentially having additional partners?
So this is Lisa. I think that came from our study. It was disclosure about taking PrEP and the idea about, you know, is it something people need to be careful about hiding? How do they explain it so that it becomes a mutually supportive thing? So it's definitely about disclosure about PrEP. Although disclosure about other partners is also probably an important area, but not what we asked about.
All right, thank you all very much again. If there are additional questions that come in, we'll go ahead and share those with the presenters to either answer live if we have time at the end of it, or to answer kind of and then share those responses back out with the community. So thank you again to Amy, Lisa, and Jessica for your work and your presentation. Now I want to go ahead and shift directions a little bit and pass it over to Wiley Jenkins, who is going to be sharing about his work with PrEP in rural areas of Illinois.
My name is Wiley Jenkins. I'm a research associate professor at Southern Illinois University School of Medicine. And largely what I'm going to be doing today is really I'll be talking about a pilot project we did at Southern Illinois. But much of my work is actually going to be a real description of the differences in both scale and scope of working in, say, Chicago, a large metropolitan area, versus much more rural areas, and some of the lessons we learned from this pilot study. And so I will attempt to share my screen, and we'll see how this goes. Hey, looks like we're going well so far. There we go. So the title, HIV Pre-Exposure Prophylaxis, Accessibility in a Rural Community Utilizing Telehealth Services. And I would like to say that this is really based in part upon a clinical trial that we have funded through NIDA right now going on in Southern Illinois, addressing infectious disease associated with injection drug use, specifically opioid ongoing trial, really developed into the idea for this. And so that you'll see that kind of sprinkled throughout as we go forward. Just a little bit about ourselves, because I don't know how many people know about us. So the SIU School of Medicine is relatively new. We were founded approximately 50 years ago. Unlike maybe other institutions, our service area is approximately 66 counties. We cover essentially the southern 2/3 in the state. And so our partnerships have really encompassed almost every health department in that area, and we have clinical locations throughout it. So really our being and much of what we do is really the idea of embracing and exploring the idea of rural health and rural health care. And my personal research has looked at rural health disparities in different types of aspects. And so my department, Population Science Policy, actually just came into being a couple of years ago. So we are truly new to this. And actually PrEP, and this PrEP project we have, is personally my first foray into PrEP and addressing HIV specifically, and again, is associated with our existing clinical trial. So this is somewhat a serendipitous opportunity we received a couple of years ago. To basically address rural HIV and rural PrEP utilization in Illinois. And we were awarded $50,000 to do this in 1 year. And the idea was to use telehealth technology to provide it in these areas. We ultimately received a no-cost extension through May of this past year, and we received our equipment from our own SIU School of Medicine telehealth area. Now, why telehealth? Well, there's a couple of real reasons why we wanted to do this. One is that in many of these rural areas, there may not be a provider that provides PrEP. Many of these rural communities, many rural counties, then someone may have to travel quite a distance, in excess of 60, 70, 80 miles just to the nearest provider, if they can find one. There's also the idea, too, of disclosure. In such small areas, the idea that, again, if there is a single provider in the community or in the entire county, that provider may also have been the person who delivered you when you were born 18, 19, 20 years ago, and may have been your pediatrician growing up. And now you're in that kind of uncomfortable position of outing yourself and disclosing your HIV risk status to an individual who maybe goes to church with you, or who you're the wife of your English teacher at high school is in the waiting room. In these rural communities, people really do know everybody. And so there's a lot of stigma. There's a lot of people who feel afraid to even approach the idea of PrEP because of the fear of lost anonymity. And so the idea of telehealth, providing a mechanism to engage with a physician that is anonymous and that provides a degree of anonymity as well as respect and lack of stigma, we figured to be ideal. And so this is based upon conversations we've had with some of our partners. So our main partner in Southern Illinois is an organization called the Community Action Place. This was founded in 2015. Their mission to otherwise underserved populations in an effort to assist in breaking the cycles of poverty, addiction, unhealthy, or unsafe behavior. Largely, they are a harm reduction agency, and to our knowledge, they are the only community-based harm reduction agency and syringe service provider in all of Southern Illinois. We have 2 syringe service providers in Central Illinois, one in Springfield and one in Champaign. South of that, this organization is it. And so they provide HIV, STI screening, they provide contraception, they provide full syringe service program, drug treatment referral, and harm reduction counseling. And they cover 19 counties. This is a mobile operation. They have, at this point, 2 vans. They also have several office locations in Cairo, Illinois, which I'll circle back to, as well as Murfreesboro and now Marion, where there is also now a methadone clinic. But again, we're talking about a very resource-poor area where this is a single one for our service, but a population of only approximately 330,000 people. Now, again, why rural areas? Why do we even care about rural areas in HIV? And again, circling back to the idea of the injection drug use and what people are calling the list, those at risk of outbreak for HIV and hepatitis are in rural areas. And for example, there is one county in Illinois that made the CDC watch list of high risk for an outbreak, and that is Hardin County, which is far southern Illinois, population 3,800 people. And there the health department is open 1 half day each week. And so the idea is, we really got to think of a different way of how we can provide services to in a population where there are few resources and in a way that they can accept. And so just a little brief introduction here to the area. And this actually may bear relevance to other types of studies, is that the southern 16 counties of Illinois are part of what's called the Delta Regional Authority. If you've never heard of the Delta Regional Authority, I'm not terribly surprised, but think of it as Appalachia along the Mississippi River. Same type of concept. Here we have 252 somewhat contiguous counties. They branch off into Alabama there. Poor economic prospects, largely impoverished, mostly medical under of the Delta region. We focused our clinical trial there. We focused other types of work there because the idea being that, if we can prove something in principle there, even in a pilot, we can make a greater case for generalizability across the 10 million residents in the other 7 states of the Delta region. So that's just something to think about when you're looking about rural and how difficult it may be to generalize from state to state. So as most people know, with PrEP as well as with real estate, location is everything. And so we have in a way, peanuts. We have $50,000 to pilot the idea of, ultimately, in combination with our partner, we chose Alexander County. So this is one of the southernmost counties in Illinois. The entire county is a population of 6,500 people. Perhaps surprising to people on this call, the county itself is 36% Black race, and 30% are below the poverty level. Cairo itself is the largest town in Alexander County. It has 2,500 individuals living in it, it is 72% Black race. And so there are a lot of potential interesting comparisons to be drawn between, say, Chicago versus Cairo, Illinois, just in terms of the economic and racial distribution, which we are looking to explore in the future. Cairo itself is resource deprived. The local health department does not have a medical clinic. It's a health profession shortage area. And kind of specifically to the work we're doing as well, we see here that they actually have increased rates of several STIs. And so the chlamydia rate in 2017 was 582 per 100,000 compared to Illinois 588. Gonorrhea is quite a bit larger. Syphilis, primary and secondary, is large as well. HIV, number of people or rates of people living with HIV, somewhat comparable. And we actually found this true, these data to be similar not only for the southern 16 counties, but also for all the rural counties along the Delta Regional Authority. And then we actually published that a couple of years ago, that these rural areas, perhaps counterintuitively, are frequently at increased risk of several different STIs. So the methodology, and just to round this out for people who may not be familiar, telehealth is essentially video conferencing a clinician to a patient. We realized very early on that there are health profession shortage areas in many of these rural areas, and we cannot just parachute physicians into these remote rural areas. We have to come up with a different way. Telehealth provides basically telemedicine. It's a video conferencing. The equipment is fairly minimal: a computer, a television screen, an otoscope, a wired stethoscope, suitable internet, and which is honestly getting better all the time. There are still areas where there are shortages. That is certainly getting better. Implementation, and this is really gets to kind of the meat of the difficulties working. We worked with a community partner in Cairo for several months, the first 3.5 months of this project, to get the equipment, to install the equipment, to train individuals, to train someone to instigate the electronic health record for new patients. We had a couple of runs. We had a full dry run. The next day, that nurse that worked at that place quit. A day later, someone else in that organization quit, and they had to pull out. And so the loss of 2 individuals meant essentially the collapse of their involvement in this project overall. And this is not to somehow speak ill of this organization, but they're not the AIDS Foundation in Chicago or Howard Brown, where there's any type of depth of resources. And truly, the loss of 1 or 2 individuals really can make a difference. And as I alluded to before, many of these agencies are only open maybe 1 day a week or 1 half day a week. And so, again, the idea is that how things will work. And so ultimately, our plan B was to pivot and locate this equipment at our Community Action Place office in Cairo, which is open 1 half day a week. And so we were able to go live with that in September of last year. Services offered, we basically, I've already talked about the telehealth technology, we were able to acquire that. We had to arrange for laboratory services. Largely, LabCorp is ubiquitous across Southern Illinois, and I think across much of Illinois. And so we were able to contract with them for the PrEP required laboratory services. We are fortunate to have several people on staff who are phlebotomists. We were able to collect the specimens ourselves and arrange for local pickup. That was not terribly difficult. Pharmaceutical was arranged through a centralized pharmacy here in Springfield, actually, where our infectious disease physician was located. The pharmacist enrolled patients into either PrEP for Illinois or through Gilead. And patients were offered the option that, you know, the medications could be mailed directly to them, or they could be mailed to our Harvard. Nearly 50% of our injection drug use population is homeless, even in Southern Illinois. A lot of couch surfing, but still, the idea of a chaotic lifestyle really contributes to the idea that this is difficult to implement. None of the participants pay for medication ultimately. Billing for medical services, and this gets to be, you know, when you talk about sustainability, is the bugaboo for everything. And so participants for this study were not charged for services. We did identify that the majority of our participants did have a some insurance, either public or private, or were eligible. Ultimately, we did not charge, but should we try to do this again or go larger scale, that would have to be part of our model. Important for Illinois specifically, when you're talking about telehealth, is that our community action place was identified as the CMS originating site for telehealth services. COVID has expanded the reimbursement rules and rates. Important for reimbursement purposes to have a brick and mortar site where these services could be provided, and this is not necessarily true in other states. So getting in the door, man, we did everything to try to get people in the door. We did a radio interview, which was archived on the radio station. The local newspaper picked it up and reported about this and about the project. We did a bunch of Facebook targeted ads in the Cairo area. We used multiple images, multiple types of messages. We had flyers posted at every place we could think of. We originally planned to advertise through Grindr, like many people would, but they had just previously to the starting suspended new advertisements, and so we were unable to make use of that. And then scheduling, it talks a little bit about the scheduling. So ultimately, what did we do? Ultimately, over approximately a 5-month period, we had 6 individuals who enrolled in the program. 3 completed the visits and are receiving medication. 3 others are still in the process, and honestly, at this point, presumably lost to follow-up, especially due to the COVID break of things. However, given the national PrEP that the population of Cairo is about 2,500 people, is this a success to even have anybody? Honestly, we don't know. It's not what we may have hoped, but it's not zero. And so as a pilot project, it's a feasibility project. We can at least say that we were able to implement this. We learned a lot of lessons, and we did get some individuals on PrEP who were not before. The Facebook advertising, honestly, we reached a tremendous number of people. 64,000 individuals or hits were recorded for our things with over 171,000 impressions. Ultimately, we did have a large community impact in terms of the number of people who were aware of the program, were aware of PrEP, even if, and for anyone who's implemented a PrEP program, even if the uptake was slow to begin with, certainly, the awareness has certainly increased, but we have not researched that, which is critically important. So keys to success, just from our perspective, and we do have other data well as those we've reached out to. COVID, unfortunately, put a kink into collecting that data. That is still ongoing. So we hope to have patient-specific information about their interaction, about their utility, their viewed utility of PrEP, about their compliance with medications. Hopefully we'll get those data in the next few weeks. As far as what we learned, though, as far as implementing PrEP in a rural area, you have to have a local manager to create the patient electronic health record. This just speeds things up from the perspective of the clinician. Continued community engagement, that is obviously critical and obviously key. And so we decided to focus initially amongst both MSM and injection drug using population. And our participants are a reflection of that. And so approximately are both. We need to develop a robust methodology for reimbursement. This will be the make or break. And honestly, it's unknown how reimbursement may change. And this gets to the last point, exploring other mobile and remote options. Iowa, for example, has an entirely telemedicine-based method for PrEP provision that is largely driven by pharmacists. And so they can do smartphone-based consultations. The pharmacist can arrange for laboratory collection pickup. That is not really doable in Illinois due to our rules. And so post-COVID, and once the reimbursement and telemedicine rules become hopefully a little more standardized and a little more generous, hopefully something like the Iowa model can be implemented here. But the lesson we learned from this is that there's something like PrEP, which is honestly a hard sell for people who have other priorities in their life, such as shelter, such as food, such as obtaining their next fix. We've got to make this as a idea of providing an anonymous, stigma-free environment is key based upon our population. And so those are the lessons we've learned from our pilot study. Those are some citations. We'd like to thank Scott Fletcher, the Community Action Place, Brent Van Ham, and Christopher Rodriguez, who worked with me and did a lot on the ground work. My contact information, and I'm happy to take any questions. Thank you so much.
Thank you so much, Wiley. And the ask is if there's anything this statewide HIV community could do to support or enhance the experience of people in rural areas providing and or receiving PrEP services. So looking at folks who might have more access to resources or various resources kind of in the northern half of the state or in the Chicago metro area, and how those folks, providers or community can support kind of our rural partners.
I'm sorry, you broke out quite a bit. I'm not sure I heard much of your question.
Sorry, I'll try it one more time quickly. So the question was about how the statewide HIV community, both providers and community members, can support PrEP access kind of across the state. So if folks in the northern half of the state or in the Chicago metro area have more access or better resources, how can they go ahead and support kind of our statewide community and folks who might have significantly less access?
Honestly, in my opinion, the first thing we need to do is meet and talk because there are 100 different models for how this could go. For example, our partner in Southern Illinois is one model that we believe is potentially effective, especially if we can make this truly mobile. They take, and they also potentially could provide PrEP by the same mechanism. Reimbursement is problematic because it's not a brick and mortar site, which is currently required. And that model is not available everywhere in Illinois. And so, you know, how do we better engage other local community-based organizations, especially in these rural areas, and to enable them to reach out, to enable them to link up, likely in a hub and spoke model similar to ECHO for training. We need to discuss, you know, are there resources available? And then what are the different partners to engage in different parts of the state? Because one thing you quickly learn is that rural is not a homogeneous concept where all rural is the same. I mean, unfortunately, every rural area is near unique. And so what works in some counties in Southern Illinois may not work in others. And so honestly, we need to kind of build the idea of a program and an idea of engaging partners on a larger scale in these for the specific area of rural outreach, and think about what is a scalable intervention in different areas.
Thank you so much for your answer. With that, we are coming to a close today. So I want to thank all of our presenters for their work in the field, but also sharing with us today, taking the time to share with us. We know PrEP is an important pillar of getting to zero work, and I know I have learned a lot, and I hope everybody else has learned a lot about PrEP in populations that are sometimes sidelined in the conversations that we have. So as we wrap up, thank you to everybody for tuning in. We've recorded the webinar and we'll be sharing it out along with any questions that were not able to be answered live today. We'd love to see you all again with us. Our next webinar in this series is coming up on Wednesday, September 2nd, also during the lunch hour, and we'll feature a data modeling team from the University of Chicago that's been working over the past year to analyze HIV, PrEP, and public health data to help us make data-driven decisions as we implement getting to zero strategies. They're going to go ahead and share their initial findings, as well as talk about the future of HIV in Illinois and our response to it. So please go ahead and plan to tune in for that discussion. The link is going to be in a follow-up email that we send out, as well as it should be placed in the chat now if you're interested in clicking and registering today. Thank you again for sharing your lunch hour with us, and I hope you all have a lovely afternoon.
Thank you.